जी
Lindsay gastrointestinal tract. One 7-day post-operative following Bildad 2 partial gastrectomy for gastric carcinoma. Then CT shows skip of free air in the abdomen, fluid collection in the right subhepatic space, which extends toward the peripancreatic area. Most likely diagnosis is leakage from the duodenal stump. Now, reason is because leakage from the gastroduodenal and anastomotic site in Bildad 2 proceeds partial gastrectomy. We do not do gastroduodenal anastomosis, so this is wrong. Post-operative pancreatitis, there is no serum amylase increase, so this is not pancreatitis. Then tumor recurrence is also not correct. Cyst formation is not correct because it occurs after 10 days, and here 7 days post-op. So answer is leakage from a duodenal stump, correct? Skip of free air in the abdomen, fluid collection in the right sublunar space, so is leakage from duodenal stump. Question number 2, barium swallow shows uniform horizontally oriented fold in lower esophagus, chain and structure of mucosa 1 cm above the hiatus, which is situated height 25 cm from the origin of the esophagus. There is a slight smooth narrowing noted 2 cm above the hiatus, beyond which there is a slight dilatation of the esophagus prior to its joining the stomach, which is an unusual finding. The esophageal fold is always the appearance of our esophageal fold. Horizontal esophageal fold is seen in feline esophagus. Esophageal fold is always vertical, and here they are saying horizontal joint fold in the esophagus. So this is abnormal finding, unusual finding, correct? Rest all are normal findings. Option B, chain and mucosal appearance 1 cm above the hiatus. It is Z9. The distance of the hiatus from origin of esophagus is also correct. The slight narrowing 2 cm above the hiatus is called A line. The slight narrowing 2 cm above the hiatus is A line, so this is also normal finding. Distal bulge just before the stomach is also normal finding. Only abnormal finding is horizontally oriented folds in the lower esophagus. Question 3, multiple hyperchoric lesions of the liver. CT shows focal enhancing lesion causing prominence of the head of the pancreas, most likely diagnosis, isolated tumor with liver metastasis. The option B is pancreatic carcinoma and liver metastasis. This pancreatic carcinoma is hypoechoic, so it cannot be an answer. Multiple hypoechoic lesions in the liver, and then CT shows focal enhancing lesion causing prominence of the head of pancreas in the pancreas head, so diagnosis is isolated cell tumor with liver metastasis. Question number 4, which is correct regarding carcinoid of the GI tract? The size of tumor at diagnosis is related to the risk of metastatic spread. Now, in carcinoid of the GI tract, the size of a tumor at diagnosis is related to the risk of metastatic spread. Number 5, epigastric pains, MLAs is 1024, high. The WBC count is slightly elevated, rest are all normal studies. Next most appropriate radiology investigation is ultrasound scan within 24 hours. Because she has pancreatitis, but we do ultrasound scan, it is slightly elevated WBC, ultrasound scan within 24 hours. GT is only in pancreatitis with severe prognostic indicator. In severe pancreatitis, we do CT scan. But here, the next follow-up investigation is ultrasound scan because the WBC is slightly elevated and rest all tests are normal. So next we do ultrasound scan within 24 hours. Question 6, ulcer on the greater curvature of the stomach. Surrounding is mound. Thin line noted which crosses the base of the ulcer and degree of retraction of the greater curvature around the ulcer. What type of ulcer is this likely to be? This is benign ulcer due to the line noted crossing the base of the ulcer. This is called Hampton line or harmless line. Ulcer on the greater curvature of the stomach, and then thin line noted which crosses the base of the ulcer and degree of retraction of the greater curve around the ulcer. This is benign ulcer due to the line. Question number 7, RTA. Read rotor action, left side rib fractures. 3D shows crescentric area of low attenuation is noted on the spleen. Area of hyperattenuation passing 4 cm into the splenic parenchyma adjacent to the hilum. Here's the splenic parenchyma uniform attenuation. Which statement regarding the spleen is true? While the appearance are consistent with the laceration and subcapital hematoma of the spleen, the radiologic findings are not reliable in determining the need for laparotomy because in grade 3 splenic injury there is 10 cm laceration. In grade 4 there is laceration to the hilum and 25% devascularization. Until grade 4 can be there is treatment is conservative treatment. So there is splenic injury, but it is not it does not need treatment. The patient is hemodynamically stable. So the appearances are consistent with laceration and subcapital hematoma of the spleen, but not need of laparotomy. Question number 8. Which is the feature of small bowel systemic cirrhosis? Answer is pneumatosis intestinalis. It means systemic small bowel systemic cirrhosis. Which all options are not fixing. Option A is also not correct. Pseudovertical seen as in Crohn's disease. This is also C is wrong. D is also wrong. So answer is pneumocystis intestinal seen in small bowel systemic sclerosis. 9. C shows thickened appendix which appears to have a defect in the wall on multiplanary primary images. So there is purpura of the appendix. Ocular fluid collection adjacent to the appendix which has bubbles within it. Visual PD finding is more specific for detection of purpura appendix. Adjacent abscess formation shows purpura appendix. More specific for purpura appendix is adjacent abscess formation. Question number 10. Stricture and distal common bile duct (CBD). Parent becomes septic and biliary drainage is required. Most appropriate method for this is ERCP with plastic stent insertion. We do not do PTC because patient is in sepsis. Then becomes septic, so in this we must do ERCP to remove the stricture. Question 11. A lesion is noted in the liver on CT and ultrasound. It is inferior, anterior, and to the left of right hepatic vein, but to the right of the middle hepatic vein. It is inferior of the confluence of the right and left portal vein. According to coronary system for segment of liver, the lesion in segment 5. Now, if you see the segment of liver and in the middle, right of the middle hepatic vein, so it will be segment 5. Question number 12. Ultrasound reveals 2 cm lesion in the right lobe of the nerve which is hyperechoic centrally with hypoechoic rim, which cannot be considered in the differential for this lesion, hemangioma. Because this lesion, hyperechoic in the center with hypoechoic rim, this is target or bull's eye lesion, and target is not seen in hemangioma. Question 13. Barium, what is the best position to place the patient to see and in face view of the lesser curvature? Left anterior oblique view. To see face view of the lesser curvature, we put the patient in left anterior oblique view. Question 14. Which is the fast recurrent peritoneal and mesenteric structure? Left paracolic gutter communicates with the subphrenic space. The left paracolic gutter does not communicate with the left subphrenic space. Question number 15. Patient is being worked up for pancreatic neoplasm to assess potential resectability. With the following does not rule out surgery. Enlarged peripancreatic lymph nodes greater than 15 mm. Because if there are lymph nodes around the pancreas greater than 15 mm, then those can be resected in reparative procedure. And here they are saying which does not rule out surgery. So even if there are lymph nodes, it doesn't matter. It is not contraindicated to surgery. We can do surgery. We can remove it in reparative procedure. Question number 16. A 20-year-old history of rheumatoid arthritis. Barium meal shows antrum stomach is mildly narrowed and wicked. Thickened rugal folds are noted. General fold measure 4 mm and the iliac fold appear more plentiful and measuring 3 mm. Terminal ileum reveals same findings as above. Both are diagnosed amyloidosis due to rheumatoid arthritis. Hint is history of rheumatoid arthritis. Then there are all increased number of folds and narrowing in stomach, large bowel, and small bowel. So this is seen in amyloidosis due to rheumatoid arthritis. Rheumatoid arthritis with increased number of folds in stomach and duodenum and terminal ileum. So this is amyloidosis due to rheumatoid arthritis. Question 17. Painless jaundice or sounds of grossly dilated intrahepatic bile duct, but no evidence of dilated CVD. Common hepatic duct is not clearly visible to an isoechoic mass in the region of porta paris at the ductal confluence, mosaic pathology, cholangiocarcinoma. Rest options don't make sense, and here the mass is in the region of the porta paris at the duct confluence. And then there is grossly dilated intrahepatic duct, so these all findings are seen in cholangiocarcinoma or clad skin tumor. Rest all are different findings. It cannot be portal metastasis, it cannot be hepatocellular carcinoma. These all do not make sense.